Hello and welcome to another episode of the Mini Battles E-Series by Athens Shoulder Course. My name is Manos Brilakis and I am the head of the organizing committee of this course. Being driven by our passion for continuous education, development and communication with our international friends, we came up with the idea of launching monthly webinars dedicated to shoulder pathology and treatment, the Mini Battles E-Series. Counting down to the next Athens Shoulder Course, we hope to welcome you and host you again live in Athens next May.
So let me welcome you as well to this Mini Battles series. I'm Manos Antonogiannakis. I'm the chairman of the Athens Shoulder Course. And due to the fact that we had to postpone the Athens Shoulder Course last year, we decided to have these mini battles. And so it was possible for us to have four friends, charismatic orthopedic surgeons, and discuss, debate about specific issues in shoulder surgery. So before introducing our guest this night, please take a moment and vote for our first question. The today's topic is about Latarjet. And which is the percent of Latarjet procedures in your practice? Less than 25%, between 25 and 50%, or over 50%?
So take your time to answer. Today is the episode number 6, counting down to the next Athens Shoulder Course. And it's dedicated to the Latarjet for shoulder stability. And we have with us 4 exercise surgeons and dear friends. And we have together Professor Dr. Berte, President of the Norwegian Society for Surgery of the Shoulder and Elbow. She's a complex knee and shoulder surgeon of the Division of Orthopedic Surgery in Oslo University Hospital from Norway. Also, Dr. Benjamin Marjanovic, the head of the Arthroscopic and Sports Orthopedic Department in the Orthopedic Hospital in Valdortra, Slovenia. Professor Dr. Michael Hantes, the ESCA General Secretary, Professor of Orthopedics in the University of Thessaly in Larissa, Associate Editor in the JBJS Case Connector and Editorial Board Member of the AJSM and KSSTA. And last but not least, Dr. Clement Ludvigsen, Consultant Professor Orthopedic Surgeon from the Orthopedic Department in Oslo University Hospital from Norway also, who will be sharing with us their experience on the special subject, the special today's subject.
So welcome again to the mini battle episode number 6. And you can submit your questions throughout the hospital, throughout the session. And we hope that we will be able to answer them at the end. We are going to have a discussion about the presentation. So the first presentation is going to be given by Dr. Benjamin Marjanovic, and it's going to be about the open Latarjet procedure. So let's start.
Do you see my screen?
Yes.
So thank you for the invitation. It's a great honor to have the opportunity once in a life to speak on such a big event like the mini battle it is. So my speak will be about the Latarjet and why I prefer the open technique. Those are my disclosure, not related to this talk. In 1954, Dr. Latarjet presents a surgical technique that he used just in 4 patients. So the first report of this technique was a small case series. Through several modifications during the decades, it's become one of the basic shoulder stabilizing procedure nowadays. Even that Bristow is often mentioned together with the Latarjet procedure, there are several differences. In Bristow technique, just the tip of the coracoid, so distal to the insertion of the pec minor, is detached, and the conjoint with a small piece of bone is passed through the subscap in the glenoid bone rim. So no screws are used. just sutures are used to fix the conjoint to the subscapularis. And just scar tissue act as a second holder of the conjoint inside the subscap. According to his original article, we don't know if Brister had high failure due to his fixation technique, or because he had this, we can say, problem with patient selection, because mostly of his patients come to the local school for epileptic patient. And unfortunately, the resolution rate in his series was very high. Today we know why the Bristow works, because you can see on this video, this is a case of a revision after a failed Latarjet in a hyperlax patient. And once we removed the screws, there was just a piece of the scar connecting it all together, the remaining conjoint, the capsule, the labrum. So it's very difficult to somehow dissect all this structure. And this is the reason why the Bristow works. Even that we have several scoring systems that might guide us to the best surgical procedure for specific patient, still we have a lot of gray zone. And also scores change during time. For example, the last study of Di Giacomo showed that using GT-IMS reduced the selection of Latarjet procedure compared with the older ISIS one. Also, ESA proposed a scoring system that take care of quality of soft tissue, for example, but still several puzzles are missing when we do patient selection. For example, how we can assess the patient motoric control over dynamic shoulder stabilizers, or what is the effect on decision making if the patient have poor motoric control, or if the patient have luxation at night when sleeping. So when parasympathicus cut all the dynamic stabilizers, and all this everything rely just on the static stabilizers. And those kind of question is still open, and maybe for the future, they will clarify a lot of gray zone that we still have today. Latarjet, unfortunately, is not a miraculous treatment. Still, we have a lot of problems, for example, in multidirectional instability, in untreated epileptic patient, where the first line is just to assess the therapy, where we have severe bipolar bone loss, like in this video, Latarjet is not enough, and we will choose some other procedure. Or we will have an osteoporotic patient when we might have problem with the breakage of the coracoid or bed screw fixation. Fortunately, in the last few years, a lot of studies come out according to DAS, ASA, capsule application, and other technique that might help us to have better patient selection. A lot of surgeons choose Latarjet as the first weapon in case of recurrent glenohumeral instability. So they go directly for Latarjet due to its extremely low recurrence rate. Maybe they're right, because our goal is that the patient needs just one operation in his life. If we look a little bit closer how the Latarjet works, Latarjet is an excellent procedure if performed correctly, and all of us knows, but how exactly works? At the beginning, we need some primary stability between the coracoid and the glenoid bone, and we have different techniques how to fix the coracoid bone to the glenoid. We know that the bigger is the surface of the contact between bone, better is the ingrowth and probably less coracoid osteolysis. Biomechanical results seems to be equal if you use screws or any other suspensory device. But if we look at clinical studies, we find some percentage of higher redislocation rate in the suspensory device. So it doesn't matter if we do it arthroscopically or open, it seems. The conjoint tendon and the inferior portion of the subscapularis create a dynamic sling effect with the shoulder in external rotation and abduction. And the soft tissue sling effect is the most significant contributor to the stabilizing of the glenohumeral joint. Deficient anterior bone glenoid is augmented by the coracoid graft And probably these two effects are the major stabilizers of the Latarjet procedure. What about the capsular repair? There are several articles that say that this is just like an extra, additional stabilizers, but with no so much clinical effect. Today we know that it's not like that, and it seems that the capsule repair don't influence so much the stability, but just it may reduce some degree of external rotation. So if I start now why I choose open comparing to arthroscopic, in red I put the debatable differences. In the literature we have several articles who compare both techniques. Their conclusions are almost identical. So the advice is to start with open because it's easier a procedure, and then we slowly should move to arthroscopic, and mostly of us did like this. When you start with arthroscopic, you should have some experienced surgeon by your side to help you at the beginning. Open has a shortened learning curve, it's logical. Shorter operating time, but just at the beginning. More pain in the short post-operative period, it's true. No big cosmetic difference if you do a small incision in the open fashion. Interestingly, the arthroscopic Latarjet technique did not show improved positioning of the bone block, as most of us think at the beginning. More complication we have in the open probably, but this is debatable. Less attractive for the patient, yes. If we look now at the one that I put in red and make some debate about it. The average time for the procedure for the arthroscopic, it's really longer, but just at the beginning. According to some article, you need around 20 procedures that you get the equal time of open and arthroscopic. So with other words, Latarjet is time consuming just at the beginning of the learning curve. What about pain? Postoperatively, however, there is some small amount of bigger pain in the open Latarjet, but just in the few first days. And also, if we look at the VAS, it's just 1 point. This is almost nothing. And if we look at 3 weeks or 4 months, according to some article, the VAS become the same. So probably, if we look at the reason is in the hematoma at the open, maybe edema formation, we don't know exactly. There are no comparative long-term study to say which one have more complication comparing to others. Why? Because in 2003, Lafosse was one of the first who started with this procedure, and then with several modifications. So we will have to wait a few more years to have more comparative long-term study. Long-term complication, it's a kind of shoulder stabilizing procedure are pretty similar, even if we do open or even if we do arthroscopic. And the main complication, as we know today, long-term complication is arthrosis. As we said before, we still don't have long-term result after Latarjet, but probably it will be the same. If you have to choose between these two patients on those pictures, probably we will do prosthesis in both of them. So even the one on the left have an arthroscopic Bankart repair with severe arthrosis, and on the right we will have again Latarjet and severe arthrosis. So probably after arthroscopic Latarjet we will have something similar to that on the left picture, but arthrosis at the end is arthrosis. In this study, the cost of the Latarjet procedure was calculated by summing the cost of the operating theater, the specific instrument used for a Latarjet, and the implanted material. And it seems that arthroscopic Latarjet is far more expensive. In some countries, you might get higher reimbursement, but this is just a few countries in the world. The number of shoulder surgeons is increasing, so you need to fight for the patient. If you are performing a procedure that your neighbor clinic is unable to perform with similar outcome, you can use it to attract patient. and similar strategies we know from other procedure in orthopedy like prosthesis. Robotic surgery attract patient even if we know that the end results are similar. In conclusion, I prefer open Latarjet. Why? Because it's an easier procedure and performing Arthroscopic is quite unpredictable. You never know what present you will get once you are inside with the arthroscope in the shoulder. And this present may be bleeding, may be difficult to scalp opening, may be difficult nerve finding, swelling, and all those problems you will never have when doing an open procedure, open Latarjet. And the second reason is that clinical, functional, and radiological results, it's almost identical. With other words, it's no improvement between open and Arthroscopic, and I don't see any advantage using complex arthroscopic technique to upgrade an easy open one. Thank you for your attention.
Thank you, Benjamin, for this interesting presentation. Before moving on with Berte's lecture, please have a look at our second poll question, which is, how do you perform Latarjet? Do you perform open or arthroscopic or arthroscopically assisted? This is the two options. Take your time, and Berte, proceed with your presentation, please.
So, thank you very much for having me in this battle, Manos and Manos. I appreciate it. And Benjamin, you are way too polite. This is a battle. I couldn't even feel you hitting me. So, here we go. Why should we choose arthroscopic? Of course, sports medicine surgeons, orthopedic surgeons, they tend to prefer the arthroscopic procedures. Converting to arthroscopic procedures is a natural development, and it's our progress. We have done it for Bankart repairs, we have done it for cuff repairs. This is the way to go. And of course, it's a lot easier treatment of concomitant injuries when you do it arthroscopically. We are also gaining experience in doing endoscopy, not just arthroscopy. When you do the Latarjet procedure arthroscopically, you have to dissect around the coracoid, and this is also useful for other procedures. For example, in AC joint stabilization, if you do it acute or chronic, you will benefit from having this experience going around the coracoid. There are some experienced people who have done this before us. This is a Polish study. The first author, he was a fellow with Laura Lafosse. He published his first 90 cases of the arthroscopic Latarjet. Of course, you use longer time for the first cases. It's a novel technique. And in this paper, he presented the time of surgery, the clinical outcomes, the complications, and the revisions and recurrence. And the learning period lasted for 30 cases. For these cases, he had longer surgery time and higher number of complications. But the results and the revision rate were similar. And in the conclusion, he says that, of course, surgeons should be aware of the increased risk of complications early in the learning curve, as for all novel procedures. This is a group of 12 surgeons, very experienced surgeons across 5 countries and more than 500 patients. What they experienced was that the operative time came to a steady state after 30 to 50 procedures. And the accuracy of the bone block positioning had a constant improvement with more procedures. And they found no change in patient-reported outcomes or complications with increased volume. So even more trials, comparing the open to the arthroscopic Latarjet. 6 clinical trials with almost 900 patients. The recurrent instability were similar between open and arthroscopic. The revision were non-significant differences, and the total complications were also similar. So, and after the learning curve, you suggested 20 cases. Some would say you need even more cases, but then the operating time was similar. And also in this systematic review, they concluded that it's technically challenging to do it arthroscopically. It has a significant learning curve, and that's why you might consider, if you just have a few cases a year, that this might be too challenging. So how to succeed if you want to change from open to arthroscopic? You have to do a careful patient selection for all your cases. And I think it's a good thing to plan for a cluster of patients when you start to do a novel procedure. And of course, you have to be meticulous about your surgical technique. And also remember that not all patients should have a Latarjet, even if it's open or arthroscopic. There are some contraindications, and there are some patient groups that need other procedures. For example, patients more than 50 years with repairable cuff tears or a static anterior instability. If you place a bone block or a coracoid in front of that, you will lead the patient to have osteoarthritis. And the voluntary anterior dislocators, you should keep them out of your operating room. And of course, the uncontrolled epileptic patients, they should have medications and not surgery. So when we started to do this procedure arthroscopically, we tried to prepare as good as we could by visiting friends, experienced surgeons. We performed the procedure in a wet lab several times before we did it in our patients. And we also invited experienced colleagues to visit, and we were 2 experienced surgeons doing these procedures together. We also tried to follow our patients very neatly with CT scans of everybody before the operation, and also constant score, and we used WOSI as the prom before the operation. In the theater, you have to play on the same team as your anesthesiologist, because when the procedure is technically demanding, you have to see. So you have to have a patient with low blood pressure and do everything you can to keep it low and to keep it stop bleeding. So here are some technical tips from our experience. This is the subscapularis, and you can see it from posterior, and the glenoid to the right, and the humeral head to the left. And we started to go almost through the subscapulari from the joint side, because that made it much easier. You're used to see the joint from the posterior, and then it was much easier to do the split from anterior later in the procedure. And also, when you're going to do the split from anterior, you need to know where the axillary nerve is, in between the conjoint tendon and the subscapularis. You can find it, and then when you know where it is, you will not injure the nerve. When you do the osteotomy of the coracoid with a chisel, very often you will have a spike when you do it. So we started to use the chisel also make a mark underneath the coracoid before we did the osteotomy from superior. That has helped us, so we don't have to prepare the coracoid graft the same way afterwards. And the switching stick is a very useful tool in this procedure. Here it's used through the joint and through the subscap, and it then leads us back to the joint when you make the split from anterior. And in this procedure, when you work underneath the deltoid and outside the joint, and you sometimes need more space, you can use the switching stick to gently push the tissue so you get more room, and to secure the nerve so you don't get close to it. And it's a very useful tool. So we always have like 2 or 3 switching sticks available during the procedure. So we did the CT scan before the operation, and even more valuable for us to do it afterwards. So you always control yourself, see that you place the graft in the right place. Because if you miss that, if you place the graft too lateral, you will turn your patient into osteoarthritic patients. So when we had done a little bit more than 100 cases, we did our analysis of the 25 first patients and compare them to the 25 last. We wanted to see how we have developed with doing this procedure. 19 of these 50 patients were reoperations. So the age and the preoperative OC score were similar in the two groups. And as expected, the surgery time went down, started out with 130 minutes in average for the first 25 and 105 for the last 25. And the results after 1 year, it's short time results, was similar in the two groups. For the radiological results, we found that the graft placement and union were better in the last 25 patients. And we were a little bit surprised of the high degree of bone resorption, and that was similar in both groups. When it comes to complications, that's a major concern when you change to a novel technique, and has been a concern for many surgeons when they consider to change to arthroscopic. We had 4 major complications in the first group and 1 in the last. And when I then call it major complications, that's patients who needed a reoperation. So the 4 in the first group, 2 of them needed arthrolysis, 1 needed screw removal, and 1 was a postoperative infection. So that's the major complications. So back to the systematic review I mentioned before. When you have a lot of patients, 6 clinical trials and almost 900 patients, you have the same rate of recurrence, you have the same number of complications, and you have less pain with the arthroscopic procedure compared to the open. So you still wonder why we should do it arthroscopically? Well, it's the natural evolution for our practice, like with Bankart and rotator cuff surgery. We will develop our skills and possibility by scoping in the subdeltoid space. We can much more easily address concomitant injuries, and it produces less pain for the patient. So I'll keep my boxing gloves on.
Okay. So, thank you, Berte, for this nice presentation. And we must remember that we are arthroscopic shoulder surgeons. And so let's continue with the poll results.
Yes, in the I have noticed that the female surgeons in this mini battle are much more attacking than
Aggressive.
the male ones. I don't know why. Maricela, Berte, and the girl from Portugal, Clara, and
It's the vegan
they took the scenario of the mini battle very seriously, and I like it very, very much. So the first question, the 93% perform Latarjet in their practice in less than 25%. And in the second and the 7% between 25 and 50% of their instability practice. And in the second question, the 8 out of 10 perform the Latarjet in open way, and the 2 out of 10 perform it arthroscopic or arthroscopically assisted. So, Michael, I need your comment. Your comment for the Latarjet, for the both lectures.
First of all, I would like to congratulate both Berte and Benjamin for the excellent presentation. As you know, or as you probably know, I'm a fan of mini open Latarjet, fortunately or unfortunately. But anyway, as you said, and I fully agree with that, arthroscopic procedure is a natural evolution in our practice, and we probably have to go to this direction. However, as Berte reported before, there are no differences between open and arthroscopic Latarjet, and I always keep in my mind that if we should go for another procedure, which should it's worthwhile to do it if we will improve our results. This is something very important, and something else is that we should take into account the cost, which is a big difference between these two procedures. Only the time will tell us if in the future the arthroscopic Latarjet will become the standard of care. However, before that, I would like to ask both speakers. To my opinion, the battle is not between arthroscopic or open Latarjet, but if we should choose as a primary procedure for shoulder instability directly the Latarjet, since it's a very successful operation, 1 to 3% of recurrence rate. So why not to go directly for a Latarjet procedure? Berte and Benjamin, what is your comment about that? We saw from the vote that 93% are doing less than 25 Latarjet procedures. So I wonder, since we have such a nice procedure, 1 to 3 recurrent rate, why not to go for the Latarjet in every patient? Berte or Benjamin?
Yes, both the open and the arthroscopic Latarjet procedure has a higher complication rate than, for example, on Bankart. So for some cases, I think it's too aggressive to go directly for the Latarjet, and it's an anatomical procedure, and maybe we increase the risk for the patient of having osteoarthritis. So it's for every patient, it's an individual consideration whether you have to do a Latarjet or not. And in Norway, we do like 90% Bankarts compared to 10% Latarjet. So even if I favor the arthroscopic Latarjet, I don't think that every surgeon in Norway should do it.
Okay, so this is very good comment. So in Norway, 90% of shoulder stabilization procedures are Bankart procedures, correct?
I don't have the exact numbers, but
more or less.
Yeah.
More or less. Okay, thank you.
Probably we could say that there are soft tissue procedures, not just Bankart.
Soft tissue, correct.
It's ASA, DAS, and all this included in this.
I fully agree with Berte's opinion. Fully agree with my question, and my comment was a little bit provocative, but let's hear what Benjamin's opinion is in this topic.
We know that even if we do a Bankart repair, we might have very good results. And several articles show that long-term complication, long-term instabilities after Bankart, it's also quite low if you choose the right patient. And maybe this is one problem or one thing on we should think about. If we choose the perfect patient, we will have also perfect result with the Bankart. So why to use a more dangerous procedure, as Berte said, to have an equal result?
What do you think, Tom?
First of all, I like to comment on the two speakers. Very nice presentations, and it's really hard to argue against any of you. The problem is, as Michael actually says, it's not actually the question of open or arthroscopic Latarjet. Both works quite well. I think it's very important to remember that arthroscopic Latarjet is a technically demanding procedure. And if you don't have a number that is large enough that you can overcome the learning curve, you should not start doing them. I'm absolutely convinced about that. And as Berte says, you should probably have collected a number of patients with the indication for a Latarjet before you start, so that you don't have to start over again with every new case, that you have a cluster of patients to start out with. That being said, We have now been doing this for 7 years, and there is no way we will go back to open Latarjet. We find it's a nice procedure. We still are working on technical and practical improvements. I think there are it's possible to improve the procedure and become better. And I think with increasing experience as a shoulder surgeon, I'm more and more convinced that as a shoulder surgeon, you need a large toolbox, and you should then tailor your surgery to the actual patient you have and do the procedure that is necessary for the problem you want to solve. And in my opinion, doing a Latarjet on every patient is over-treatment with high risk for the patient, both in long time outcome, but also in immediate post-surgical complications.
Berte, I have a provocative question for you. Why do you think that a lot of surgeons who start with arthroscopic Latarjet abandon it and they go back to the open?
It might be because they find it time consuming, that they still use longer time for the arthroscopic procedure, and maybe because of the expenses.
Benjamin, which are your main concerns for trying to go arthroscopically?
As all of you, I think we also try with arthroscopic Latarjet. We did a few cases, but then we didn't see any difference, and this is the reason why we moved back. Maybe if we did 100, 200 cases, we will stay on arthroscopic, but we moved back because we didn't see any difference. It was almost the same. Maybe again, we need bigger numbers.
So I can turn the question back to you. Would you go back to open Bankart or open calf repair?
No, because we know which is the problem of the open Bankart, and we know that this procedure, even if make a good stability, you lose a lot of external rotation. And we see several cases of patients with open Bankart with bigger complications. So I will never go back to open Bankart.
So as I'm a little older and I remember all the debates about open and arthroscopic, I remember the debate between open and mini open and arthroscopic ACL reconstruction in the knee, and then the debate between open and arthroscopic Bankart repair, and then about the mini open and arthroscopic rotator cuff repair. And what we know now is that if we debate point to point, practically there are no differences. When I was debating about the arthroscopic Bankart repair, the other battler was saying that I can do a Bankart repair without detaching the subscapularis, just splitting it through, and then the results were the same, and there was no difference between the two procedures. At the end, what is important that drive us to arthroscopic surgery is that we have a much better understanding of the shoulder or the knee when we do arthroscopic surgery, because it gives us a completely different view of the anatomy. And this is the main advantage to do arthroscopic surgery. It's not that if you take procedure by procedure that you are going to see many advantages, but at the end we learn more, and learning more about how the joint works, functions, we can find procedures and find solutions that are more effective and with less complications and an easier post-operative period for the patient. This is the main advantage, I think, of, in general, arthroscopic surgery. And this goes for Latarjet also. Latarjet is a difficult procedure, either open or arthroscopic. It's not the technical difficulties, it's that we are changing completely the anterior anatomy of the shoulder. the main reason I don't like it and I don't do a lot of arthroscopic or Latarjet procedure is that I'm afraid of the complications. What I have in mind all the time is not the positive result that we are going to have less than 1%, for example, recurrence rate, but how I'm going to solve the negative result, what is going to, how easy I can solve the complications that I may find, I may have after a procedure. And this is make me reluctant for the Latarjet, for the initial good question of Michael Hantes, why not to do Latarjet to all the patients. And also, it's very, we must thank Laurent Lafosse because he opened a new space for us. And now we can operate easily in the subscapularis, in AC reconstructions by driving and pushing the limits of arthroscopic surgery from arthroscopy to endoscopy. And I remember back to 2000 when it was impossible to repair, for example, the subscapularis arthroscopic, and now it's common practice. This, what do you think, Tom? You are
Manos, that I cannot come along actually one single thing that we disagree upon. We have the same kind of experience, and we have the same kind of philosophy, and I think we agree on most points. And I totally agree that arthroscopy is expanding your horizon. You learn about. If it wasn't for arthroscopy, we would not know about bicep problems. We would not know about slap lesions. You can debate how to treat them, but still, there's a lot of things that has come out of arthroscopy. And I totally agree. It's not actually the every procedure, the discussion if this procedure should be done like that or done like that. It's in my world, it's a question of evolution, and as so many others also mentioned, no one would go back to open ACL surgery. That's what I learned when I was training. No one would go back to open subacromial decompression. That's also what I learned. I was the first in Norway to present the series of patients with subacromial arthroscopic decompression, and I was really very badly treated by the old professors who said that how can you possibly talk about such a stupid operation? If you want to see, you have to open up. This is old-fashioned. This is not the 2020. We need to try to continue the evolution, try to find new ways, and try to expand our horizon. And that's why, as Manos correctly says, arthroscopy is not the tool of the devil, as Rockwood says. It's the tool of the 21st century.
Yeah, but don't take it in the wrong way. I mean, me, Benjamin, and other shoulder or knee surgeon, we are doing, and we love arthroscopy as well, definitely.
Yes, of course.
This is a specific topic, and I think that it's not a fair comparison between ACL surgery and Latarjet. It's completely different topic. Anyway, for me, the main thing is that it seems that we all agree that Latarjet procedure should not be the operation for everybody, and I fully agree on that. So my next question would be, what is your operation for a failed Bankart procedure?
Are you asking me?
I'm asking the speakers, first of all. Berte,
speakers, yes.
Yes. You might notice that 19 of the 50 patients I reported when we evaluated our learning curve, they were revisions. So of course, if I have a patient coming to my office who has had a Bankart before, I will have a lower threshold for going to the Latarjet than for a first patient. So in some cases, we decide in the operating theater. When we do the arthroscopy and assess the labrum, if it's still solid, if it's been a new trauma, you might repair it again. But if the soft tissue is no good, we proceed to a Latarjet procedure. So if it's a failed Bankart, I will have definitely a lower threshold to do a Latarjet.
Okay, Benjamin?
If once the Bankart failed, there is no reason that it will work for the second time. So I almost never go for a second Bankart repair. Okay, there are some exception, but very, very rare, like hyperlax patient or badly controlled epileptic patient, where you have to do something at the end, because otherwise the shoulder is outside.
We're not talking about epileptic patients. We're talking about normal patients, athletes, or
Yeah, I go almost always into Latarjet after failed arthroscopic Bankart if it's my patient. If it's patient from someone else, it's debatable. It's I have to visit. I have to look to all the scores, to everything, because it's my patient. I go always, in case of failure, to the Latarjet.
what's the difference? What's the difference if it's your patient or a patient?
Because I know exactly, because I do like flying a plane, always the same step. So I know exactly what I did in all the patient. If come from someone else, I don't know how much he detached the capsule. I don't know how he put the anchor, how he make the knots. So I'm not sure that the procedure was doing correctly.
Tom?
I think it's in medicine, it's nothing as always or never. It's always a mix, and we can agree that the anatomy of the shoulder may vary a lot from patient to patient. Someone has a well-developed labrum and strong ligaments. Others may have a very tiny little labrum and almost no Bankart lesion at all with the first operation. So you need to take into account all these factors and look into your toolbox and find the solution that you think will be sufficient for the actual patient. And I think there is a lot of things you can do in between the two far ends, the Bankart at the one end and the only Bankart at the one end and the Latarjet at the other end. In between, there's a gray zone where a number of patients can be treated with different modalities, and you can have great success if you tailor your surgery to the actual patient.
Yeah, to be honest, as Berte said, if the labrum is of good quality, somebody could go for another Bankart. But most of the times I feel that another failure, it's not the result that the patient should accept. And most of the times I'm going for a Latarjet as well. What is your opinion about patients who had a primary Latarjet and a failed Bankart repair and Latarjet? Do you see any differences in the recurrence rate between these two populations?
What's the question?
Patients who had as a primary procedure a Latarjet and patients who have a Latarjet after a failed Bankart repair. There are some papers that reports there are differences in the recurrence rate between these two populations.
I have experience with both open and arthroscopic Latarjet. I haven't really had such a number of patients that I think I can stratify these groups. But my personal experience is that it's not really a big difference. It's more other factors that tend to determine the outcome. And failures after Latarjet are difficult to treat. These are complex.
I don't mean failures after Latarjet. I mean patients who had failed Bankart repair treated with Latarjet, and patients who had Latarjet as a primary procedure.
Yeah.
Do you see differences in the recurrence rate?
I haven't seen any difference in the recurrence rate. That's as I said, our numbers aren't big enough that we can stratify on that. It's my personal experience that it's not really a big difference between these two cases. But all patients with recurrent instability after former surgery are, of course, more difficult to treat than a patient that has never been operated on before.
There was a paper from the Stedman Clinic, Dr. Millet, this summer, and they reported lower return to sport if it was a Latarjet after a failed Bankart compared to a primary Latarjet.
That is
But
correct.
that was only return to sport. It was not about recurrence or instability.
Let me ask some questions for the audience, Mike.
Yeah.
Benjamin, what's your approach for persistent pain after Latarjet? From Abdulhamid Misir.
So, firstly, we have to find the reason of the pain. We know that if the patient had any degree of arthrosis before we go to Latarjet, he will surely develop surely develop an arthrosis after long term. So we need to find the cause. If it's arthrosis, if it's, for example, a slap lesion that was missed, or was a cuff tear, or any other reason. So we have to firstly find out the reason and then treat the reason for the pain.
Okay. Berte, from Marwan Buluddin, what about the IC score in your indication between open versus arthroscopic Latarjet? Do you have some decision-making point about this?
Do you mean
relative to the IC score?
Between open and arthroscopic Latarjet, or between Bankart and Latarjet?
No. Between open and arthroscopic.
I don't do open Latarjets. I do them arthroscopically.
Okay. Okay.
So I think the ICC is a score to decide between a soft
Bankart and Latarjet.
not
Yes,
Okay.
and
This was the question.
and I always I have the IC score back in my head, and I as I said during my presentation, for every case I do an individual considerations. I count the risk factors. I look at the CT scan if there's a bone loss, but that's more to decide whether it should be a Bankart or a Latarjet.
Yes. Berte, do you had the 84% satisfaction rate in your patients in the
Yes.
first group and in the last group?
Yes.
Which are the reasons for the patients that they was not satisfied? Because they had a very stable shoulder after this procedure. Why the 15% was not satisfied?
Yes. Some of them are stiff. 2 of the reoperations, they were stiff shoulders, so we had to do arthroscopic arthrolysis. And one of them were screw removal. So, and that's not the only patient where, at least for a period, they have had irritation from the screws. Most of them then had irritation anterior in the shoulder from the screw heads, and maybe the screw heads became more prominent when you had bone resorption. But also another patient, not among the 50s, she was a very skinny woman, and you could feel the screws posterior going into her infraspinatus. And that's also another screw removal we had to do. So those are some of the reasons I can think of.
Okay. Tom, yes, Benjamin, please.
No, I would like just to comment that one thing is satisfaction of the patient and another thing is complication. Because if we used to treat just professional handball player, we will have very low satisfaction rate, for example. And if we treat normal people, we will have a very, very high satisfaction rate. So probably this depends a lot of the type of the patient we treat.
However, the group of the patients that that was included in this study was difficult patients, because there was 2 out of 5, the 40% was recurrent patients, and also I noticed one more thing that there was not simple cases. Tom, I have a question for you. We read about a complication rate about 15%. However, when I talk in person with surgeons that perform Latarjet, they always answer me that this rate is lower in their hand. What is your opinion about this?
Latarjet is a complex procedure performed either open or arthroscopically, and you have to expect it's a complex procedure performed in complex patients. It's not realistic that you can have 100% success rate with 100% satisfaction rate. And as Benjamin says, you have to look at the patients you treat. Our patients had a high percentage of athletic activity, or at least recreational sports, and of course with shoulder that, remember, our results in the study is at 1 year after operation, and not every one of them had returned to sport at the same level. So it's actually not to wonder that some of them are not fully satisfied with the procedure. 15% out of 25, that's not many patients.
Yes.
In a high-level athlete, would you propose an arthroscopic or open Latarjet? This is a question from Vasilios Mitrousias. Do you believe that there are differences in performing this surgery in this population? Mike, what do you think? Or Tom, yes, please.
Yeah. In a high-level athlete, I would make absolutely clear, at least if it was shoulder and athletics that involve the shoulder, I would say to the patient that there's very little likelihood I can do you as good as you were before you had your injury. That's number one. Number two is, as a surgeon, if you treat a high-level athlete, you should do the method that you have the most experience with. And there is no question that for most of us who don't treat a high number of patients, it's much easier to start doing open Latarjets than arthroscopic Latarjets. Arthroscopic Latarjet demands that you have a reasonable volume.
Mike?
I would say that as we discussed before, there are no differences between open or arthroscopic, but if we take into account that we have to deal with an athlete and we have to offer him the best solution to have a stable shoulder, I would go most of the times for a Latarjet, any open Latarjet.
Yes, probably it has to do with the experience of the surgeon.
Yeah, of course.
You have to feel confident with what you are doing and do this that you feel more confident. Yeah, I don't think that you can find
that
difference.
is true, but based on the recurrence rates and the literature so far, most of us would go for a Latarjet for a high-level athlete. I don't know the opinion of the
open. We discuss about open or arthroscopic, not about the decision.
I don't think that's much different.
Yeah.
Benjamin, do you perform a concomitant Latarjet and replissage, or you believe there is no reason to do replissage?
I have just one indication to do it together. This is hyperlax patient with heel sacks, because we know in the hyperlax patient, they can reach very high amount of external rotation and abduction, and they engage faster than a normal patient. So we usually, those patients treat like this. We do a CT. We measure the diameter of the coracoid, and we see how big is the bone loss anteriorly. And we do a simulation on a CT with our classic technique that we use for navigation. So you know it better than me. And then in those patients, if we see that it's hyperlax with a huge amount of external rotation, we measure it and then we simulate it And in this case, yes. Otherwise, no.
Still, you have to do arthroscopic the Latarjet, the Brilakis, and then
Yes.
continue open
Yes.
to do the Latarjet.
And I would like to add this: even if I do open Latarjet in any patient who have pain and instability, always go inside. It doesn't matter what the CT or MRI said. Always, where there is a pain inside the shoulder and the shoulder is unstable, I would like to check all the structure and to touch all the structure. So it takes me maybe 15 minutes, but I'm sure that I will not miss something.
Okay. Berte, you said that the main problems is the shoulder arthritis and the osteolysis of the graft. Do you have some tips for avoiding these problems or for improving the results?
Well, for the osteoarthritis, obvious you shouldn't place the graft too lateral. That might happen sometimes. So that's why I recommend everybody to do a CT scan after the operation, because that might be a disaster for the patient if it's too lateral. About the osteolysis, I don't think I said that was a big problem, because we don't know if it is. Because maybe it's because of the loading. If you use a bone graft on a glenoid that doesn't have that much bone loss, so maybe it's the human body forming the graft. When you don't load it with the humeral head, it will resorb. I don't know. And also we have several reports that the clinical results are still good even if you have a lot of osteolysis. So what the osteolysis means, or the resorption of the bone means, we don't know that for sure.
Yes. So about osteoarthritis, we have to remember also that from where we start, because many patients that are candidates for bone block procedures are already having cartilage damage due to the previous operation and due to previous many dislocation episodes. So,
Yes. And if they continue dislocate, they will also have osteoarthritis.
And I think Benjamin had shown that the rate of osteoarthritis after Latarjet is having a connection to the cartilage damage that they found at the original operation, at the Latarjet operation, at the time of the Latarjet. And this was connected to the severity and number of osteoarthritic changes later.
On long term.
And
so do you have
Latarjet, by the way, because we are now trying to see what happens with Replisage, and we found a similar connection between the initial presentation of the patient and the number of and severity of osteoarthritic changes after Replisage, 10 years after Replisage.
But probably, Manos, any procedure that you do to somehow make stiffer the shoulder, like latissimus dorsi transfer, or calf repair with overtensioning, everything that compress the joint, so the humeral head again, the glenoid, probably, if you have some degree of arthrosis at the beginning, it will lead to increase the severity.
Yeah.
For certain, if you have a stiff shoulder after any procedure,
Yes.
then probably you are going to have a higher rate of osteoarthritis. And this comes for all the operations, for putti plat, for all this capsulorrhaphy osteoarthritis. And this comes for calf. Happily, most of the time, the shoulder compensates and slowly regains the motion and solves the problem. The nature solves the problem that we created. Okay.
So, do you have something to add?
I think it was an excellent battle. Probably we don't have the winner, but
Actually, in all this series, we understand that there is no real battle, but it's a matter of we have the same problems and we try to think about them and solve it.
So what we can say as a conclusion is that if you are familiar and feel good with an open Latarjet, then you have to do, it's good to do it this way. If you want to challenge yourself and want to proceed to arthroscopic surgery, then you have to pass a learning curve that is going to be difficult, and you need help for this from another surgeon or from an experienced colleague to pass from open to arthroscopic surgery. If you pass to arthroscopic surgery, then you have to improve the way you do it. And always we have to keep in mind that we can improve what we do in order to lower the rate of complications or avoid complications. And this is not only for Latarjet also. It comes with anything we do. And now we are seeing that Latarjet is trying to do without screws. We put buttons, we put sutures, and try to avoid hardware near the joint, or try to calculate where to put better the graft. All this has to do with the evolution of the procedure. All the procedures we do are evolving, trying to avoid the complication and have more consistent results.
So this is the end of the today's mini battle. Thank you for your participation. Thank you for attending. See you in next episode, December, dedicated to posterior superior calf tears. And we remind you that in order to earn the CME points, you have to fill a tiny questionnaire, which will be sent to you by email. You can always follow Athens Shoulder Course on the Facebook page and LinkedIn, and stay in touch. And of course, follow VMed, because there are many interesting webinars hosted in the forthcoming period. Thanks, Johan, for attending. Thank you for being here.
Thank you all. And don't forget that 2022 is near. And on May, we are going to have the next live Athens Shoulder Course. Thank you all.
Good night, everybody.
Thank you. Good night.
Good night.
Good night.
Thanks for the discussion.